who is a professor of diabetology in University of Liverpool, and will summarize and translate into practical considerations. Thank you.
Okay. Thanks very much, Roland. So my task for the next 40 minutes or so is to try and bring this all together and to do this in a way that hopefully will keep you all interested and perhaps having some thoughts around what you would do when faced with patients who might be suitable for SGLT2 inhibitor treatment, using the information, the very extensive information that we have heard this afternoon. These are my disclosures. And the way we're going to do this is we're going to look at some clinical cases. So we'll start off with George. And so we're going to go through the history of a patient with diabetes, if you like. So George is 42 years old. He's recently been diagnosed with type 2 diabetes, although he's had borderline diabetes, impaired glucose regulation, whatever you care to call it, for the last 5 years. But now he's hit the point where he's actually developed diabetes with an HbA1c of 58 millimoles per mole, or 7.5%, which has increased over the past year. He has a history of hypertension, which he's had for 8 years and for which he takes Ramipril. And relevant, perhaps to the discussion later, he's a fireman, so he drives a big truck. His blood pressure is, as you can see, quite well controlled, but he is overweight but not obese, with a BMI of 29. So he's already taking his Ramipril for his hypertension, but now he's been told he's got type 2 diabetes. He's a little bit worried about this because obviously he doesn't want to be feeling unwell at work. And the first polling question that I'd like you to think about is, what do you think would be the most appropriate medication for this gentleman as first-line therapy? Three-quarters of you would have given George metformin. There is a few who would have given him an SGLT2 inhibitor, obviously taking on board some of the excellent discussion that we've just heard from my colleagues, and a few would have given a DP4 inhibitor, and there's one or two brave souls who would have given him a sulfonylurea or a meglitinide. So I think most of us would agree that metformin still holds that place at the top of the guidelines. Whether that will change as we see the emerging data on cardiovascular protection with SGLT2 inhibitors, I don't know, but I think that would still be top in the guidelines. But of course, there are some people where, with the best will in the world and all the right counselling about exercise and taking it after meals and so on and so forth, that people just cannot tolerate metformin. And of course, there are also contraindications, not relevant in this case, in relation to renal function. So we do have to think about, what do we do if George finds that metformin doesn't suit him? And of course, if we're going to do that, we have to think about various things. How high is the HbA1c? Some guidelines advocate using dual initial combination. Not my own favoured preference, but it is there in some of the guidelines. Whether other comorbidities might influence our decision-making process. So if the patient's got significant renal impairment, an SGLT2 inhibitor would clearly not be the right choice because it's not likely to work. If we're worried about hypoglycemia, and clearly for somebody who's driving a fire truck and may be in hazardous situations, hypoglycemia would be a very major concern, and I certainly would not give George anything in this situation that might increase his risk of hypoglycemia. Some people would recommend injections, but that might not be a very popular first choice for a lot of our patients. And we have to discuss and individualize the adverse effect profile with the patient. We all live in a cost-conscious world, and certainly where I work in the UK, our guidelines are quite strongly cost-driven, so that might come into the equation as well. But we also need to think about the other effects on the pathophysiology of type 2 diabetes. We need to think whether these agents might be helping with body weight, perhaps helping also with blood pressure, or having effects on lipids that may be favourable or unfavourable. And we have to weigh all this up and then come to some sort of decision for those patients where metformin is not considered the right first choice for whatever reason. So the ADA-ESD position statement is actually fairly clear on this. It makes it clear that you can use sulfonylureas, meglitinides, thiazolidinediones, DPP-4 inhibitors, GLP-1 receptor agonists, or SGLT2 inhibitors as alternatives in patients where metformin is not suitable. And then you've got to make your mind up as to which is the most appropriate for an individual. But it does give us some guidance and suggests that if renal function is a problem, then DPP-4 inhibitors, whether it's one that you can adjust or don't need to adjust in terms of renal function, either would be okay, would probably be the best option in that specific situation. So let's look at the data with SGLT2 inhibitors as monotherapy. If, let's say, George doesn't get on with metformin, would an SGLT2 inhibitor be a good choice? We've already said sulfonylurea meglitinide, probably not a good idea. I would argue thiazolidinedione, probably not a good idea because it's going to make him put on weight, and he's already overweight. And he's got normal renal function, so we could consider a DPP-4 inhibitor, but we could also consider an SGLT2 inhibitor. We've seen these data already, but you can see that for canagliflozin, for dapagliflozin, and for empagliflozin, as monotherapy, these agents are quite effective at lowering HbA1c with reductions between just under 0.5 up to just over 1%, depending on the dose, and depending a little on the baseline HbA1c as well. But you can see for these studies they're all around about 8%. So you'll get most patients to a reasonable target if you make that choice. And if we look at the alternative, which was the DPP-4 inhibitor, there are head-to-head studies of sitagliptin against metformin. Sitagliptin is less effective than metformin. And linagliptin is also effective as monotherapy. So we could also choose a DPP-4 inhibitor here, and that would be a perfectly reasonable choice. Okay, so we'll come back to George. 4 years later, he's actually okay on metformin. We've started him on metformin, and the dose has been titrated. He's taking 1 gram twice daily. He's been on that dose for 2 years. And he actually originally had quite good control, but over the past year things have started to slip, and he's now gone above the decision point of an HbA1c of 7.5%. His HbA1c is now 7.9 or 63 millimoles per mole. He's got quite reasonably controlled lipids. LDL is 2, HDL is 1.1, triglycerides are 2.3, and as you can see he's got normal renal function, but his blood pressure is certainly above the level that I would consider acceptable for someone with type 2 diabetes. It's 144 over 92. So, I'm assuming that most of you would want to add another agent at this point because his glycemic control is not good and he's only relatively recently diagnosed with diabetes, still only 4 years into his disease. So you want to avoid something that's going to cause hypoglycemia. So I'd be interested to know what the audience would do here. And it looks like you've all been listening, because most of you would have chosen an SGLT2 inhibitor. We know George is overweight, he's a little bit hypertensive, so that seems to be okay, but there's quite a significant proportion have chosen a DPP4 inhibitor or a GLP-1 receptor agonist, and there's still a hardcore who might consider a sulfonylurea or meglitinide. So we'll just think a little bit more about this, and I think we've already had this discussion from my colleagues here. George is now 46. Remembering his A1C is 7.9%, so to get him down below 7, and some people might argue we need to get him even lower than that, we need him to get a drop of at least 1%. We have noted already that he is overweight with a BMI of 29. His blood pressure is not optimally controlled, but he does have good renal function. And very importantly, I don't want somebody driving a fire truck who's at risk of hypoglycemia, so I certainly would not give this guy anything that might cause hypoglycemia. So those are the things that we need to think about. We also need to think about adherence, because one of the other factors that we know really is quite a strong predictor of long-term outcomes in people with type 2 diabetes is adherence to therapy. If you don't take the medicine, it's definitely not going to work. And we know that people who don't take the medicines actually have worse outcomes, presumably for that reason. So let's look at some of the data around hypoglycemia as in drugs added to metformin, just to push home this point about not giving this guy something that might cause hypoglycemia. You can see that across the board here, if we look at the newer agents, that the risk of hypoglycemia with DPP4 inhibitors, with GLP-1 receptor agonists, with thiazolidinediones, with drugs like acarbose, alpha-glucosidase inhibitors, and with SGLT2 inhibitors is really low. It's effectively placebo-like. So these drugs, because they do not stimulate insulin secretion, and of course they're not insulin, really don't cause hypoglycemia. As soon as we start looking at data around meglitinides or sulfonylureas, or of course basal insulin or combinations and premixed insulins, the hypoglycemia rates rise very significantly. And for somebody who's driving as part of his job, or somebody else like frail elderly people where they might be living alone, we need to consider that hypoglycemia risk. And the ADA-ESD guidelines recommend the agents that don't cause hypoglycemia, which are the ones that I've already mentioned. So we've had this debate about SGLT2 inhibitors or GLP-1 receptor agonists, and also combining perhaps with DPP4 inhibitors. And it's interesting that what we see here in type 2 diabetes patients, if we look at on the left-hand side, these are patients who are combining canagliflozin, either 100 or 300 milligrams, with DPP4 inhibitors, and we can see that there are significant reductions in A1C, and likewise if we combine with GLP-1. The choice that we had, the other choice that we had was actually, in addition to metformin, whether we add an SGLT2 inhibitor or a gliptin. And I think it's very interesting when we look at this data, which of course Guntram is very familiar with, showing that canagliflozin 300 milligrams actually is superior to sitagliptin in terms of HbA1c lowering. So for this patient, where we want to get an HbA1c reduction of 1%, it could be argued that the SGLT2 inhibitor is more likely to achieve that than sitagliptin. Likewise, if we look at data with empagliflozin, again combining empagliflozin with sitagliptin, or comparing empagliflozin sitagliptin as an add-on to metformin, again we can see that that combination of the three drugs gives a better glycemic control, and also that the SGLT2 inhibitor gives a better effect on body weight. So, to sum up case one here, metformin is, I think everybody would agree, is the initial treatment of choice, but we've discussed possible second-line agents if metformin is not tolerated or contraindicated. We have to think about the patient factors when we're selecting an alternative agent as second-line therapy, but I would argue that SGLT2 inhibitors are particularly useful here because, especially in an overweight patient who's hypertensive, they will have benefits on both weight and blood pressure and have a low risk of hypoglycemia. Okay, let's move on. Next case. Elizabeth. This is a little older now, 52-year-old lady. She's had diabetes for 4 years. She's hypertensive. She's got dyslipidemia. Her blood pressure is quite well controlled. She's overweight. She's pretty good with her exercise program. She's walking about 5 kilometers most days of the week, but she's struggling with losing weight despite all the counseling she's been getting. And she's currently treated with a combination of metformin and glimepiride, so dual therapy. She's also on an ACE inhibitor, a statin, and some ibuprofen for pain. She comes to your clinic and her HbA1c is 61 millimoles per mole, or 7.7%, and you'd like to see her down below 7%, and that's been progressively increasing over the last 12 months. Everything else is within normal or acceptable limits. She does have poor glucose control, and you're confident that there are no symptoms of hypoglycemia, and she's doing a bit of self-glucose monitoring and is not seeing any hypoglycemia. So she's doing okay from that point of view. So let's have a think about what we might do next here. Would you push harder on the diet and exercise? She's only just outside the targets. Could you increase the glimepiride? It's one option. Would you add another oral agent? Or would you swap her away from the glimepiride and add another agent instead? So this is quite interesting. So we've got just about half, or exactly half of you saying that you would stop one drug and switch her for the other. We can have a discussion about that. There are about a third suggesting they would add a third agent. And we have nobody wanting to increase the glimepiride, and a significant minority suggesting she should try harder with a diet and exercise. So that's interesting. Durability is a problem, and these data just show the example of this. This is from the ADOPT study, and you can see that sulfonylureas are probably the least durable, and of course after 3 or 4 years of therapy a lot of that effect has worn off. However, there's no doubt that if you then stop, even though you've got that loss of durability, if you stop therapy, the HbA1c is likely to go up. So I would argue that perhaps stopping one drug and swapping it for another, you may actually still not get the patient to target, and then you might end up having to still add a third agent, albeit perhaps a different third agent. So I'm not sure there's a completely right answer to this, but if a patient is stable on a sulfonylurea and is not getting hypoglycemia, my own choice would probably be to add a third agent, but I don't think those of you that would discontinue the sulfonylurea are necessarily wrong. So let's make the suggestion that we do add another oral agent. So I'd be interested to know what you think we should do next. So about 2/3 of you would go for an SGLT2 inhibitor, just under a quarter for a DPP-4 inhibitor, a few would add a thiazolidinedione, not completely wrong here, and a few would add basal insulin. Again, perfectly within your rights to do so. It's in the guidelines that you could consider that. So let's just move on and have a discussion about that. As Guntram has said, individualization and discussion with the patient is actually key here. And again, it's down to how high is the glucose. Clearly, if the glucose is very high, it might be more appropriate to add insulin. Are you worried about hypoglycemia? Is the patient worried about hypoglycemia? The body weight comes into it, and I would argue very strongly that if the patient is overweight or obese and is concerned about their weight, then we should be choosing something that is at best weight neutral, or at worst weight neutral, or at best is causing weight loss. Obviously, we need to consider the comorbidities, and we need to consider access to treatment. And those effects of the agent come into this as well, including their ability to lower blood glucose, risk of hypoglycemia, etc.
Can I add something?
Yes.
Can you go back to the slide? One
Yeah.
second? So in my view, the most important variable is missing here. So this will be the result of cardiovascular endpoint studies.
Yeah.
So I would expect that this variable will have the most important power in decision making in the future. And personally, I would expect that all three SGLT2 inhibitors should arrive at the same result at the end, since they have the same working mechanism. They are not so different. Yeah?
That's a very brave statement in advance of we don't even know the details.
Yeah, of course. But anyway, but I believe if it's true and it's confirmed later on, this will be the key factor in the decision process.
I do agree with you there, but I will wait for the results before before putting my money on the table, as it were. So let's think about Elizabeth. She's relatively early in the course of the disease. We want to get her down by at least 1%. She doesn't seem to have any particular problems that would make us worry about hypoglycemia, but that's a discussion we need to have with her, because once people get hypoglycemia, they really don't like it, but she is overweight. She's on metformin and glimepiride, and then again we're having to consider the HbA1c, the hypoglycemia risk, the cardiovascular risk factors, and of course adherence to therapy. And if we're thinking about what might fit best here, we want to get a good HbA1c reduction. GLP-1 receptor agonist, sulfonylurea she's already on. Thiazolidinedione is considered highest. Insulin, of course, is the highest of all. DPP-4 inhibitors and SGLT2 inhibitors perhaps a little bit less so. We want to choose something ideally that's low risk for hypoglycemia. We want something that's going to be at best cause weight loss, or at least be weight neutral. We need to consider the adverse effects, and we need to consider the costs. Remembering this lady's already on the low-cost agent of sulfonylurea, so we are down to really that choice between DPP-4 inhibitors and SGLT2 inhibitors if she's particularly concerned about her weight, which she's told us that she is. So we've already seen versions of this slide. So the important things about SGLT2s, HbA1c reductions, weight loss, and blood pressure reduction. And if we look at the data where SGLT2 inhibitors have been added in this situation in clinical trials to metformin and sulfonylurea, you can see that the HbA1c reduction with canagliflozin is between 0.85 and 1%, empagliflozin around about 0.8%, dapagliflozin a little over 0.8%, so they're all effective in this situation, and they would all be an appropriate treatment choice if you were choosing an SGLT2 inhibitor. If we look at the effects on body weight and blood pressure, again, we've seen a lot of these data already, but you can see that the weight loss is around about 2.5 kilos. The blood pressure reduction is around 4 millimeters of mercury. So let's say you do decide to add an SGLT2 inhibitor. What's the most important side effect that you're going to tell her about? So I think most of you chose genital urinary tract infections. Some patients do get a bit of thirst because of the polyuria, but that's usually very small numbers of patients, less than 1%. GU infections in a woman may be as much as 10 or 15% depending on the trials, and so it is important to discuss that with the patient. The other key adverse events that I think it's important to mention, we've already had these summarized, but if we can just move on to the next slide, are of course the genital tract infections. There isn't really a lot of evidence that these drugs actually increase bacterial urinary tract infections. It's really the fungal infections that we worry about. I've already mentioned the rare cases of polyuria and volume depletion, but if she was on a loop diuretic, we'd need to be very careful. Hypoglycemia is very rare with these agents, but it might occur in combination with the sulfonylurea. We've already discussed the effects on lipids and the ketoacidosis at length, and also the bone fracture risk, but those are things that you do need to mention to your patients. So to summarize this case, we've talked about that diabetes is progressive disease and that you do need to escalate therapy if the disease progresses, and you need to do it rapidly to keep patients at a good level of control. And you need to consider the individual factors when you're making that treatment decision. And we've seen how we can use the ADA-ESD guidelines to help guide that treatment choice. So for the final case, we'll move on, we're going to talk about Kate, who's a 70-year-old lady. She's got type 2 diabetes, dyslipidemia. She's had diabetes for 12 years. She's obese with a BMI of 34. Her blood pressure is well controlled. She's on metformin and basal insulin in the form of insulin glargine, 56 units a day. She's also taking simvastatin and a multivitamin, and she's a retired school teacher. The problem is that she's been on 56 units, but the insulin requirements have been progressively increasing. She's now on 80 units a day. Now remember, most of the pens, and the glargine pen I know, has a maximum dose of 80 units. So that's going to be a problem if you want to increase insulin. She's going to have to take more injections one way or another. She's also gained about 6 kilos in weight, and her HbA1c is progressively increasing, but it's not too bad. It's 7.3%, and her glucose levels are around 6 to 8. What could you do for Kate? Well, one option would be to add an SGLT2 inhibitor, and here's some data from a trial with dapagliflozin where exactly these sorts of patients were chosen. In fact, they had worse HbA1c than Kate. The average HbA1c was about 8.5% in this study. And you can see if you just titrate the insulin up, you can get some improvements in glucose control, but if you add the SGLT2 inhibitor, you get a greater reduction and improvement in glucose control. The difference is around 0.6% at the end of 2 years of follow-up. What you can do there is break that cycle between the increasing weight and the increasing insulin doses, and you can see that the SGLT2 inhibitor completely stabilizes the insulin doses, the body weight. In fact, you get a little bit of weight loss. The difference in body weight is about 3 kilos. And if we look at what happens to the insulin dose, we've broken that cycle of increasing insulin doses and increasing body weight. So the difference for the patient at the end of 2 years is about 18 units of insulin. And that can be achieved without overall increasing the risk of hypoglycemia. And we have the same sort of data for canagliflozin. This is a sub-study of the CANVAS study, which is the ongoing cardiovascular outcome study, looking at 18 weeks. And again, you can see that adding the SGLT2 inhibitor to insulin is able to reduce the HbA1c, and it's able to do that whilst reducing body weight and also reducing blood pressure. So if we're trying to target these risk factors, this is a very good way of dealing with this and breaking that cycle of weight gain and increasing insulin doses. And so I would argue that for Kate, this would be a very reasonable thing to do. because it would prevent her gaining more weight, it might cause a little bit of weight loss, and it would mean that she could stay on 1 injection a day rather than having to take more than 1 injection a day. I think we'll just leave that. So, just make sure you've all been listening. Her EGFR is 68. There's the rest of her biochemistry is there, but I don't think we need to worry too much about that. You can see the numbers. So the question for you is whether it's appropriate to start an SGLT2 inhibitor based on an EGFR of 68. And the answer is no, yes, but you need to adjust the dose based on her renal function. Okay, so some of you say no, most of you say yes, and some say yes, you have to adjust the dose. Kate's EGFR is 68. The cutoff point for dose adjustment for SGLT2 inhibitors is 60. So at 68, you don't need to adjust the dose, and there's no reason why you can't start an SGLT2 inhibitor. We just move on. And here's the detail on this. So it is slightly different for the different agents. For dapagliflozin, it's very simple. It's 60. Above 60, you're fine. Below 60, don't start it or discontinue it. For empagliflozin, above 60, no need to adjust. Don't start if it's below 60. But if it falls below 60, then you need to reduce the dose to 10 milligrams and discontinue because it won't work, not because of safety, if it goes below 45. And for canagliflozin, you can actually start at the 100 milligrams as the starting dose, but above 60, you can actually increase up to the 300 milligram dose. The dose limit for 45 to 60 is 100, so that's where the dose adjustment comes in. And again, do not initiate or discontinue if you're on it if the EGFR drops below 45. So it's subtly different for the different agents, but 60 is really the point where you need to think about whether you need to adjust the dose or stop the agent. And here's the data that supports that, and this is just looking at efficacy based on different factors, so age, gender, race don't affect efficacy, nor does BMI. The two things that are most important here are the baseline HbA1c, and this is 100 milligrams, this is 300 milligrams of cana, so the higher HbA1c, the bigger the reduction, and the other is the EGFR, and the greater the EGFR, the greater the reduction, but it's still getting pretty good efficacy, even down to 45 to 60, as we saw earlier. So to summarize the final case here, we can use SGLT2 inhibitors on top of basal and even combination insulin therapy, together with other anti-hypoglycemic agents, and that's a way of breaking that vicious cycle between insulin doses and weight gain. And if we're going to use SGLT2 inhibitors as part of our armamentarium for diabetes treatment, we have to remember that these drugs depend on your kidneys to work. So if your kidneys are not working, the drugs won't work. It's not that they're dangerous in this situation, it's just they don't work as effectively. And so for mild CKD, you don't need to worry. Below 60, you may need to dose adjust between 60 and 45, but you'll still get some efficacy. Below 45, you don't want to use these drugs at all because they probably won't work. So I hope this has been a useful discussion. We've talked about SGLT2 inhibitors. We can use them as monotherapy, as dual therapy, as triple therapy. We can combine them with insulin. And we've got these additional benefits of blood pressure and weight reduction with a low risk of hypoglycemia. The most important adverse effect, and not to say the others aren't potentially important, but the most common adverse event are the GU-type infections. From the point of view of the learning points, I hope you've found it useful, that you will now consider this new class of treatments really across the spectrum of people with diabetes. It's not going to be the answer for everybody, but for some of our patients, I think these are very useful new drugs that we should be pleased that we now have available. Obviously, we need to be careful and aware of the potential adverse effects. And so, as with all things, we have to be, cautiously moving forward and be sensible. But at the end of the day, I do think that this group of drugs are going to be very useful for our patients with diabetes. So thanks very much for listening. Thanks to everybody. I hope I've thanked everybody I'm supposed to thank. And all have a good evening and enjoy the rest of the EASD.